The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone, and welcome to the Chamber of Commerce's webinar about the Affordable Care Act for small businesses. Thank you for joining us for this lunch hour session. My name is Kyle Clark-Sutton. I'm the Advocacy Associate at the Chamber, working with Liz Irwin. I'm excited to introduce our presenters very shortly, but just want to cover a couple technical items first. For the presentation, everyone will be muted, but at any time you can submit a question and we'll collect those and circle back to those questions during our Q&A time, unless there's just a flood of the same kind of question that we need to address right in the moment. Secondly, throughout the presentation and at the very end, you may see a poll pop up on your screen, and that's just for us to gather feedback about this session. We really want to make this useful to our members and gauge whether or not it would be a good service for us to provide in the future on other topics. So whenever you want to submit a question, there should be a questions tab in the panel that GoToWebinar has up on your screen. So anytime that you want to ask that question, please feel free to submit it. It won't disturb the presentation, and that way you can capture your thoughts as they come to you. Next, I'd like to introduce our speakers. Chris Schrader has more than 25 years of experience in executive management in privately held companies, encompassing domestic and global assignments. He's held leadership positions in operations, sales, finance, and HR over the course of his career. He's also our unofficial resident expert on healthcare policy here at the Chamber, as he serves on a couple of our committees and has been a really excellent resource to us. Doug Johnson is the founder and managing partner of JA Benefits. He has an extensive background in financial and employee benefits planning with over 25 years of industry experience. Doug has served on numerous advisory boards for insurance companies and third-party administrators, and he is a frequent speaker on industry issues. So I'm going to turn it over to Chris Schrader now to take us away for the first part of our presentation.
Thank you very much, Kyle. Appreciate the opportunity to speak today. And looks like I don't have control yet, Kyle. I'm sorry.
Okay.
There we go. Got it. Okay, everyone. Thank you. Here's the brief agenda for today, and we'll move through this relatively quickly. Of course, if you have any questions, send those to Kyle. But the intention is to move through this, provide you with as much information as possible over your lunch hour here. And this session is being recorded, so you'll be able to go back to it. So we're going to talk about the current state of affairs of the ACA, the plan of requirements being imposed by it, a bit of an update on the Indiana insurance marketplace, which is where people are buying individual insurance policies under the ACA. We'll talk a little bit about the SHOP marketplace. This is the marketplace created for small business persons to be able to go and shop for insurance there, and this would be as opposed to individuals participating in the individual marketplace. Then we'll talk about plan designs, features, costs, and then the options available to small business people. So let's move to the current state of affairs. Of course, we had an announcement day before yesterday. IRS came out and said another postponement of the employer mandate. Now the law defines a large employee as an entity that has 50 or more FTEs or full-time equivalents. The IRS in this regulation has created a new delineation that doesn't really have any foundation in the law. So I'm not yet certain as to the statutory validity of this, but this is nonetheless what they have put out in terms of regulation, and so we have to treat it as enforceability right now. But they have drawn a delineation between the 50 FTE up to 99 FTE. So with those who are below 50 or at 50 FTE or below just below 50 FTE rather, they don't have to comply until January 2016 for up to the 50 to 99 rather. Now, if you've got more than 100 FTE, that's full-time equivalents, then the change for you has to do with the offering that you have in terms of your policy. So the target to hit and comply with the act, if you've got 100 more FTE, is to have at least 70% of the employees at your company be eligible for the insurance. They don't have to take the insurance, they have to be eligible for it. So that's a 2015 goal. And then when you get to 2016, that's got to be 95%. So the practical effect here is that for the majority of employers in the United States, because that's the majority of employers, that 50 to 99 FTE, that's the lion's share of employers in the nation. Not the lion's share of employees. The number of employees employed by that size of company is smaller, but that's the lion's share of employers. And so the news there is that postponed until January 2016. Small businesses, if you are on this phone and you have fewer than 50 FTE, and I expect most of you do, you're not required to provide a health plan to your employees. Now, this doesn't mean you might not want to for strategic reasons, to attract talent, etc., but you have no burden under the ACA to provide health insurance. The individual mandate, however, remains in effect, and so the expectation of the federal government is almost everyone is expected to be insured by March 30, 2014. So while you, as a small business owner, do not have a duty to provide health insurance plan to your employees if you have fewer than 50 FTE, the individuals have an accountability on their own to get insured. The open enrollment for the ACA began on October 1st of 2013, and because this is the first year of it, everyone actually has till the end of March 31st, to get coverage that takes effect yet this year. So again, this is a feature that you see because it is the first year of the plan. In future years, open enrollment is going to be in the fall of each year, and that will affect enrollment that will take effect on January 1 of each following year. So again, for 2014, everybody has till March 31st to secure coverage either in an employer plan, through the federal government, Medicare, Medicaid, something like that, or an ACA marketplace plan. So let's go ahead and look at the federal marketplace. Now in Indiana, of course, we didn't do our own marketplace, so we have a federally facilitated one. We do know that the launch in October was disastrous by any serious measure, but the website performance, and I'm talking about the user interface here, has steadily improved, but there are still some front-end issues. First and most serious, to my thinking, the subsidy calculator. This is the one that looks at the amount of income that the enrollee is stating that they have at the household level, and then it is cranking out, working through an algorithm to determine whether that individual or some individuals in the household should be tracked toward Medicaid or CHIP, or is the income level so high that they should then progress through the remainder of the enrollment process for an individual insurance policy. This calculator has about an 18% error rate. This has been the bug in the machine. They've not been able to hunt, and so it results in miscalculations. So it either miscalculates the net insurance premium, or it incorrectly routes family members to Medicaid or CHIP. And this is still happening. There's no real remedy for that. Unfortunately, it's pretty much pop goes the weasel, and because there's no transparency in it, it's not like you can sit down with a calculator and run the numbers yourself. So it's either going to route you correctly or it's not, but you're not going to know necessarily either way, and an 18% error rate is very high. The Spanish language site, if you have employees who are looking to sign up and English is not their first language, we do know the Spanish language site is up, but it has very poor translation. The translation engine that they used to take the language on the English website and translate that into Spanish just did not do a very good job. And so it's not intelligible from a Spanish standpoint for a lot of users. So it requires people to translate the translation. So it's additional burden on anybody who's helping these folks, such as navigators. And then the additional problem is that even if you get through that, all the forms are still in English. So the expectations there for that community are not being met. But if you've got employees where English isn't their first language, Spanish is, they're not going to be in for a clean ride, unfortunately. There are still very serious back-end issues. The state Medicaid interface has not yet been built, and this is an enormous challenge, and my personal forecast is it won't be solved this year. This is where the data captured on the ACA is supposed to travel to the state Medicaid agencies. The inherent challenge there is that state Medicaid agencies are all working off legacy software. As a matter of fact, state Medicaid agencies may be the largest employers of the last COBOL engineers in the United States. The technology built on the ACA side, of course, represents far later era, if you will, technology, and so marrying that and translating that data to these disparate legacy systems is a Sisyphean task almost. So that's not built yet, and that's gumming up the works for the states, Indiana included. The payment mechanism for the insurance providers was never built. You may have heard some language about the federal website never had a cash register. This is referring to the ability of an individual purchaser of a policy in the plan, let's say they picked an Anthem plan or a MedWise plan, the ability to just click and purchase that policy, pay the first premium, much as you would in almost any other e-commerce format. That functionality was never built, nor is there any functionality for the federal government to cleanly pay the insurance companies. So that's another priority for them. The biggest issue that they're going to face is that profile change capabilities weren't built either. This is for life change events. So let's say you enroll in December, you have coverage in January and February, in March you get married, you want to add your spouse. There's no mechanism in the ACA, rather not in the ACA, but rather in the federally facilitated marketplaces for an individual to be able to do that. So you put your data in, it's static and it's fixed and it can't be changed. That's another serious back-end problem. So if you look at the things that certainly must be bedeviling you by now, a lot of very, very good questions here, and unfortunately not tons of very concrete answers. And that's because this act remains very much a work in progress. I can honestly say in all the years I've had in dealing with federal law and state laws and helping my companies that I worked for and later my clients, I've never experienced a law like this where it could literally change on a daily basis. It's a very tough target. So let's look at the 2014 mandates, what all plans must comply with. So again, the plans here have to comply. You as employers purchasing plans will see these features. These are duties and burdens on the insurance companies relative to baseline plan design that they have to meet. So waiting periods, annual limit prohibition, pre-existing condition limits, wellness incentive, all these things that were loaded in now come online in 2014. Additional requirements for non-grandfathered plans. What you'll see there have to do with the essential health benefits. These are, you've heard a lot probably in the news about the minimum requirements of everything that has to be in every single policy, and these being cost drivers in the policies. That's exactly correct. And essential benefits are required for non-grandfathered plans, including clinical trials, limits on deductibles, especially in the small group plan arena, limits on out-of-pocket maximums, and then provider non-discrimination. So that's another series of things that come on. Additional requirements: fully insured non-grandfathered plans may not discriminate in favor of highly compensated individuals. Now, this has been effective since 2010. Self-funded plans have long been subject to a very similar thing for a long, long time. However, on January 15th, the IRS announced that it has not yet made rules nor created reporting mechanisms for any company to be able to actually reflect back that these fully insured non-grandfather plans don't discriminate. So on January 15th, the IRS announced that it's deferring enforcement of that particular piece of the ACA for yet another year. So if you kind of get the idea that there's a theme here, there is. We're seeing a lot of delays because the bureaucracy is truly struggling to model regs, rules, and reporting mechanisms around this just monstrous act. The reinsurance tax. This is a tax that insurers and plan sponsors of group health plans must pay. This is one feature. Every small business person, I'm sure, understands this. Anytime a fixed cost is passed along to a business, it either has to absorb it or it has to pass it along to its customer. In this particular case, I've seen no evidence the insurance companies are doing anything different other than directly passing this through to their customers. And so in 2014, you're looking at $63 per covered life as a tax that has to be paid. This applies for 3 years. So this tax is being created so that there will be the wherewithal and the funding to pay the insurance companies for the losses that they are going to take in the first year of the plan. So when you hear people talk about the bailout money, for instance, that the insurance companies are going to receive for the losses in the first year, this is where that money came from. Individual taxpayers. President Obama, however, directed in January, told the IRS to exempt Taft-Hartley union plans, basically, that's Taft-Hartley Act, from this tax. So anybody that's on the phone that has a business whereby you don't have your own plan, but you use unionized labor and you pay into a Taft-Hartley plan the portion that you must to provide health insurance for those unionized workers. What this is referring to. So that $63 that you see applying to private sector employers does not apply to private sector unionized plant employers. They dodge that bullet. So let's look at definitions of employment classification. Full-time is 30 hours or more per week for more than 4 months out of the calendar year. And you may have heard recently there was a bill sponsored by Representative Young in the House. A very similar bill was sponsored by Senator Donnelly last year to basically do away with this 30-hour piece being full-time. They want that to be 40 hours, and organized labor is stoutly behind that. But there's no evidence that will change, and the president has stated emphatically that he will veto any bill that hits his desk that looks like that. So even though there's legislative activity, even though you may have heard about it, this is indeed the reg, and the numbers in the Senate pretty much dictate that this won't change. So regardless of what's happening, whether you support it or not, this is the reg. Part-time is less than 30 hours per week, and seasonal is less than 140 days or 4 months a year. And if you want to learn more about this or see this, you can just grab this link, drop that into your browser, and see the same thing we're putting here, but it won't be in this condensed fashion. Here is basically a graph that shows you kind of how many full-time employees do you have, and then what is the implication relative to the ACA? So obviously, if you have fewer than 50 FTEs, you see here on the left side of the screen, or sorry, greater than 50, I should say, then the business is subject to the ACA. If you have less than 50, then you have to look to see if how many part-time employees you have to determine if you have full-time equivalents, because again, the most critical thing in this calculation, it's not how many employees that you have. It's whether or not they get to FTE status. So if the total of full-time and full-time equivalents is greater than 50, then you're subject to the Act and you face the penalty and coverage provisions in the whole 9 yards for not complying with the Act. If the total calculation, however, is less than 50, then the business is exempt from all these things. So again, you don't have to comply. So that calculation can be tricky for small businesses that employ a lot of part-timers or use a lot of seasonal help. This is a calculation that is critical to determining whether or not you fall under the Act. And then you can see here for separate businesses under common control. The one thing that the government put into place here is they did not want companies to be able to avoid responsibility for providing health plans by separating or segregating their businesses. So they built in strict rules around common control. So if you think you've got 100 employees, 100 FTE, or sorry, rather, I've only got 90 FTE. I'll split these into two separate entities of fewer than 50 FTE, and boom, I don't have to comply. No, that's incorrect. The government saw that coming and built regs around it. So the key issue there is common control. Now, the good news is owners and family members don't count in this calculation. So I'm sure a lot of the businesses on the phone are sole proprietors, small businesses, S-corps, and whatnot. So you can see here that there is protection within that in terms of counting toward their numbers. And you can also see here how this applies relative to family, siblings, nephews, fathers, and aunts. So if you're that type of company, you indeed do have protections here. So this means that their hours of this group do not apply to the FTE count. So as you're looking at your companies, you can go ahead and pull those folks out. The key thing where I've seen people making mistakes, and I've talked to a number of my clients about this, is actually calculating FTE. There's actually a formula for it that the IRS laid out to determine this. And so basically you add all the hours, and you have to count hours, mind you. This is not days, this is hours. Count all hours worked for employees per month. You divide that by 120, and the sum will be the number of FTEs an employer has for the Affordable Care Act purposes. So again, it's the hours worked, divide that by 120, that's the FTE calculation. So let's go ahead and look at a couple of examples here to put this into practice. So we have a company here that has 40 employees, and they're working clearly more than 30 or more hours per week. So those folks are going to count as full-time. Then you have another 25 working greater than that. That's a total of 2,700. So you take the 2,700 of these folks, divide them by the 120, and you get another 22.5 FTEs. So you add the 22.5 to the 40 to get that, and now you're at 62.5 FTE. So simply counting these full-time employees will miss the calculation, and you'll arrive at an incorrect result. So the correct result we see here by this formula is 62.5 FTE, which means this employer is subject to the Act. This is the formula to use. So let's look at example 2. Here we have 40 employees working the 30 or more hours a week, but we've only got 15 employees, and they only work 600 hours per month. So we take that 600, we divide that by 120, and those 15 heads reduce down to 5 FTE. You take those 5 FTE, you add them to the 40, you've only got 45, that is less than 50. This employer is not subject to the Act. So I can't emphasize enough how important it is to be able to have a grasp around these hours and to be able to carry out this calculation. Knowing whether or not you're subject to the Act is the key first step in your orders. So with this, I'd like to turn over the next part of the presentation to my colleague, Doug Johnson.
Thank you, Chris. We're going to jump forward a little bit now and essentially take a look at maybe some options for you, because you've heard Chris talk about the different particulars in terms of the law and how that's going to potentially work. But you also now must put this in somewhat of a context in terms of what we can do and how that really applies to you as an individual. And Kyle, can you hand the controls over to me so that I can advance the slide, please?
I've got you listed as having control. Is it not working for you?
I'm not getting it right now.
Try your mouse. Or did?
Okay, there we go. Thank you. We put together a decision grid that I think might be helpful in terms of how you would look at a particular situation for the Affordable Care Act and how it might apply. If you look at where you fit in terms of the decision grid, if you've got higher paid or higher wage employees or lower wage employees, you would move left to right on the grid. As you have a more highly skilled workforce, you probably may have a culture that would lend itself to making the benefit plan still more of a recruiting and retention tool. And as you have maybe lower skilled, lower wage employees, you might be more inclined, if they would be eligible for the exchange or for subsidies, to might look at not keeping a plan. And this would apply for mainly employers below 50 lives. And Kyle, I'm getting a lot of feedback on the audio. I don't know if that's coming through to everybody else or not, but can you mute one of your lines there?
I think it is. We're all muted over here. Let me see if I can. So I see two. Let's give it another try. Go ahead and say something, Doug.
Okay. Does that help? Is that a little bit better?
Well, it's telling me that two phone callers are speaking, so I don't know. Do you have your? You just have one line connected?
Yeah, I've just got one line connected.
Yeah, I'm sorry. I'm not sure what to do. Maybe it'll clear up.
Okay, well, we'll keep going forward here. Hopefully we'll make this work. Again, I think culture is determined as to whether you want to keep a plan or not keep a plan. You probably also have to look at your risk profile as an employer and whether it makes sense to keep a plan or not keep a plan. The healthier your plan is and the healthier your workforce is, the more likely it's going to make sense for you to keep a plan. And the less healthy or more high-risk profile you have as an employer in terms of your demographics, the less likely it might make sense for you to keep a plan. So this grid just sort of illustrates that and gives you an opportunity to look at different ways to do things in terms of where your particular plan might fit. In addition to that, it looks like if you're on the right side of the grid, you may want to keep your plan. If you're on the left side of the plan, and the lower left in particular, you may want to look at dropping a plan or looking at other alternatives. And let's take a look at some of those other alternatives. For the exchange place in the marketplace in Indiana, you really have 4 different options for individuals to go to the exchange. For the individuals that go to the exchange, especially in the Bloomington marketplace, you're probably limited to mostly Anthem or MD-wise plans, which MD-wise is sort of the IU health plan, if you will, marketplace product. THP is very strong in the Fort Wayne area, and Celtic Life is another player that has mostly northern Indiana covered under their particular marketplace product. Within the marketplace and part of the federally mandated insurance marketplace, you will see metal level types of plans that are available to you. Essentially, I think what you may want to do is look at the metal levels, bronze, silver, gold, and platinum. And essentially, those metal levels create what are called actuarial values. The lower the actuarial value, the less the benefit plan is. The higher the actuarial value, the better the benefit plan is, and what we've typically referred to. I'm going to try to mute my phone again. And actually, it doesn't work if I mute. I'm still sure I have one line open, but I apologize for the feedback we're getting here. You might ask, okay, what does the meta level essentially do for me in terms of specific deductibles, and what's that really look like? The average silver plan deductible these days looks to have a deductible a little bit more than $2,500. And so that's what you could expect to see in a silver plan. The bronze plan typically has a deductible that is more than $4,300. And I think if there is one thing these deductibles are compared to everybody else, or maybe what people thought they were going to be, we're seeing a very, very high deductible options in the marketplace. And typically, this is what we're seeing is some of the market frustration, I think, in terms of what people thought they might be available to receive in the marketplace. For those individuals, every individual is required to have health insurance with a few exceptions beginning in 2014. The penalty for no coverage is $95 per person or 1% of household income, up to $285 per family this year. It increases to $695 or 2.5% of income in 2016. There are a few exceptions, essentially financial hardships, religious hardships, American Indians. If you're uninsured for less than 3 months, there's an exception for that as well, so if you're in a transition. And then also for income below the tax filing threshold of $9,500 in 2011. Other insurance changes for 2014, pre-existing conditions are no longer permitted. Age ratings are limited to 3 to 1 in terms of the lowest to the highest. Health status rating variances are not permitted, so you can no longer rate based on health status. Gender rating variances are not permitted, male or female. No more industry rating variances are permitted. Tobacco use variances are permitted, so you can't have smoker versus non-smoker rates, so that does change that. And family size and geographical variances are continued to be permitted based on your locale and family size. If you look at most small groups in Indiana and in the Midwest and really across the country, approximately 70% of the employers that we see in the small group market are better than average risk. And let's take a look and see how that really affects you. If you're looking at the community rating, we'll take a look at that. We'll also talk about the shop exchange. We'll also look at potential options with association or other affinity group plans. And we'll also talk a little bit about alternative funding options. When we did a recent look with one particular carrier, we've got 45 organizations insured with this particular carrier. Roughly 36 of those employers will get a significant rate increase of somewhere between 10 and 120% due to community rating. The healthier your group has been historically, the larger the increase will be. We did have 9 groups of the total that are slated to be a rate hold or less than a 10% decrease. If you look at individual groups, we looked at groups in different cities across southern Indiana. And you can see, based on group size, different increases across the board, anywhere from 30 to 120%. And we're going to see this probably all across the state, and in most states that are out there that have somewhere between a 30 and 100% increase if they're not currently on community rating. And most employers in most states, or many states today, aren't under a community rating, with the notable exceptions being New York and California. So what about this shop marketplace? Does that potentially serve as an option for you? I think the shop marketplace may be something that does fit for your organization, especially if you're looking to drop a plan or have limited access for some employees in that. It possibly could work. The shop marketplace is open to employers with 50 or fewer full-time equivalent employees. If you have less than 25 employees, you may qualify for a tax credit if you buy insurance through the shop program. The intent is to have multiple insurance options available for employees to choose from and let the employer pay the bill. So many of you may qualify for shop. In order to use it, you have to offer coverage to all your full-time employees, generally, typically those more than 30 hours. In many states, however, you will have to have at least 70% participation. In Indiana, we're still trying to work through some of those rules to see what makes sense. Typically, employers who apply for shop coverage between November and December can enroll without meeting that requirement, so that's a possibility. There is a shop marketplace in each state, but you must have an office or employee work site within the shop service area to use that particular shop. Kyle, I'm not sure what's happening, but I've lost control again. So if you could, Kyle, could you advance the slide for me? I apologize, folks. We seem to have been able to lose control here.
Have you lost control of the PowerPoint, Doug?
Yeah, I'm not able to advance the slide. Okay. If you could do that for me, that'd be helpful.
Yeah, certainly can.
All right. The Indiana shop program, unfortunately, we're limited to one carrier in 2014. Hopefully, there'll be more options in 2015 for us. But as far as for 2014, we're very, very limited, and there's a very limited amount of plans. I think there's only 3 plans available, and they're only bronze plans, so there's not a lot of benefit or a lot of choice there for that shop option in Indiana this year. And if we could advance again, Chris, Kyle. A couple things that I do think are potential out there for small employers are affinity or association plans. There are several of those that have popped up. It's bringing together multiple employers of a similar industry for the purpose of pooling benefits. Many of those are self-funded or minimum premium arrangements that do add flexibility and potential for financial reward. They're typically ERISA-type plans. And these groups can risk rate. So if you're someone that would benefit from being risk rated, the premiums under these types of options may be actually very helpful to you. It does require your employees to typically complete applications with medical questions still, but it does give you the potential for the best possible rates. And there are several of those association plans now in place. And Cal, can you advance for me again? There are also several other alternate funding options out there that we'll continue to see. Partially self-funded programs with some stop-loss insurance, which many larger employers have used for years, and also minimum premium plans that are quasi-partially self-funded plans that look more fully insured but still have the benefits of being partially self-funded. They're fairly innovative. They look and feel like a fully insured plan, but they actually are partially self-funded. And some of those are going down as low as 10 employees. So a lot of employers are going to be potentially having the option to use these. The benefit there is the plans become an ERISA plan, not subject to state mandates. They typically require employees to complete applications again, but they do basically benefit the better risk groups. And Kyle, if you want to advance, I think that gives everybody sort of some of the options that are out there. And I think we have time for a few questions that Chris or Kyle you may want to respond to, as well as myself.
Well, thanks a lot, Chris and Doug. Thank you, everybody, for bearing with us with the technical difficulties. We couldn't resolve it on our end, but if there are any questions, feel free to raise your hand digitally or type your questions into the question window, and we can address that as they come. Well, if there are no questions, I don't know, Chris or Doug, do you have any other comments or things you had to rush through to meet your goal that you'd like to go back and talk about now?
I think this is Doug. I think the only comment that I would add is that we most likely will continue to see changes and administrative changes happen throughout the year as they try to continue to fine-tune different parts of the law to make it a little bit more user-friendly for both employers and members out there. So I think the constant theme we'll see in 2014 is more change.
Kyle, the only thing I would add would be that the delay that came out day before yesterday also had elements that spoke to defining whether or not volunteers fell under the act. There was a lot of concern that volunteer fire departments were going to be dragged into this and it would shut down volunteer fire departments across the nation. The IRS had issued a earlier ruling indicating that they were indeed to be covered under the act. The announcement most recently declaratively said that's not the case. They also issued some further guidance about how to count the hours of adjunct faculty staff at the collegiate level, and also did some further definition around seasonal labor. Another part of the act that was delayed, this was an element that would have required all plans to cover dependent, to offer dependent coverage. There are plans, not tons out there, but there are plans that offer coverage only to employees. In 2015, plans were supposed to be modified to offer dependent coverage. That was supposed to be uniform. That was also delayed until 2016 by the IRS announcement.
Okay. Thanks, Chris and Doug. Does anybody have any final questions that they want to get in here? Okay, we've got a few coming in. So I'll just read some of these out. If you are a small business with about 30 employees of average health and want to avoid community rating, is a PEO or partial self-funded or some other option the best way to accomplish that?
Doug, I'll go ahead and speak to the PEO part. I think you can field the others. The issue as to whether or not to actually control your employees to the degree that you control them today, I think, is as much a strategic one as a tactical one. I wouldn't necessarily let the act itself drive me in that direction. However, that is indeed a potential strategy for managing the costs associated with having employees. When you move to a PEO environment, you do retain substantial control over those employees, but the actual carrying costs of the employee are mitigated by virtue of them being associated with a larger group. So generally speaking, you can expect greater harmonization of costs of everything around the employers, right? The unemployment tax, if you will, the benefits, payroll administration. There's usually a good opportunity in a PEO arrangement to drop those overall carrying costs of having an employee down. But as I said, I think that's more of a strategic decision than a tactical one.
Doug, any comments on that question?
Doug, can you take the rest of it?
Yeah, in some instances, I think from a risk profile, the PEO may be an option for you. I think, as Chris has stated, the PEO option is probably a bigger decision process than maybe just the health plan. I think the health plan is a piece of that puzzle. I'm not sure if the only reason you're going to a PEO is for the health benefits. I'm not sure that makes a lot of sense. There may be other options out there that can do that without losing control and the way you normally have done business in the past with your employees. So I think it's one of those situations you want to look at and evaluate, but it probably is a bigger strategic issue than just the health plan issue.
Great, thanks. So our next question is, why the disconnect between the deductible maximums for non-grandfathered plans and the available shop plans? Which deductibles are higher than the limits?
Scott, can you repeat that for me? I want to make sure I understand the question clearly.
So why the disconnect between the deductible maximums for non-grandfathered plans and the available shop plans, where deductibles are higher than the limits?
I think the non-grandfathered plans have typically had options to do different things above and beyond what the maximums are, but the maximums for the shop plans now are $6,350 on an out-of-pocket maximum for singles and $12,700 for families, and that's the maximum we'll look at going forward. On a grandfathered basis, you really had no limitations on what you can do in terms of out-of-pocket maximums, either higher or lower than the shop plans and or the essential health plans moving forward, or qualified health plan moving forward. So we're under the new rules, and under most of the plans you're going to see from here going forward, they're going to have those kinds of maximums involved in there, although they did more liberally interpret those rules than what they originally discussed and were originally in the law. Originally, the maximum deductible was going to be $2,000, and they've really went away from that, I think, based on the fact that they couldn't get plans to be affordable without allowing the providers and the insurance companies to develop plans with much higher deductibles and out-of-pocket costs than they originally intended.
Okay, Chris, do you have any feedback on that? Anything to contribute?
No, I don't, Kyle. I think that was very complete.
Okay, so next question. I have a small 13 FTE employee business with an Anthem plan with 7 participating. How will I know if it's more economical or fair to stop offering the plan and instead just pay what the plan costs to those participating and let them go to the marketplace?
Cal, I think the one thing that you would want to do there is to look at what your potential costs are going to be under the new rules beginning with community rating in 2014. It probably depends on whether this employer did an early renewal plan in December or moved to the new community rated plans in January. If the renewal date was in 2013 and prior to December, I think you should be able to get a pretty good idea now or very shortly in the future as to what the community rating costs will be, and that will give you an idea as to whether you need to look at keeping a plan or whether it may be more advantageous to drop a plan and provide just a dollar amount in salaries for individuals to go look at options. The other thing that you'll want to consider is what the demographics of his group are, i.e. what typically is the average pay for his workforce and how many of those individuals might or might not be eligible to go to the exchange and get a subsidy, and at what level would the subsidy level apply.
Chris, anything to add there?
Cultural, I think there are cultural implications to that. If the reason that the plan was there in the first place was to attract and retain the right type of people, then you need to examine whether or not that attraction could hold in place if the plan wasn't there. And I'm not suggesting it could or couldn't, but the one thing I would caution you on is that I've had a lot of experience in my career with employees complaining mightily about the quality of benefits, and then going absolutely ballistic when I tried to make changes to those or put in another benefit in place, since the other one didn't seem to have very much support. So don't assume necessarily that because folks not may be evidencing to you that they highly value those benefits, they may actually do so more than they are evidencing, and you may run into trouble if you try to take them away. So I think a necessary step before any move would be to have a discussion with them to get a fix on that.
Great, thank you. So we've got one more question. If anybody out there has another question, please feel free to submit it. We've got some time. So this question is, if you go to a self-funded plan, but the insurance carrier gives you a quote to laser off high-risk employees, would those employees still be eligible to get insurance in the marketplace?
Kyle, most of the carriers we're looking at on the small group self-funded or partially self-funded types of products, you're not going to laser anyone off. The lasers probably that you would typically find in a large group, and what somebody probably means by a laser is an individual deductible being much larger on one individual based on a health condition than anybody else in the group. And typically under these small group self-funded type of plans or partially self-funded types of plans, that would not happen. What the carrier would do in that case is probably price the product much out of the range in terms of what makes any sense to do, and would make it more expensive than someone could find in one of the public shop exchanges or on the community rated basis. So I think only the employers that have individuals or even have a group that meets a better risk profile will have a situation that they're benefited by being in one of these alternately funded types of plans.
Thanks, Doug. Anything to add to that, Chris?
No, I don't. I think that was very complete.
Okay. Well, we are coming towards the close of our hour. If you have any more questions, get them in right now. Alternatively, you can email me as well. My email address should be in your GoToWebinar emails that you got to connect with us today. And as you close out, as we end the webinar, there will be a small survey that will pop up on your screen. and you'll also receive an email. So if you can't get to it now, you could do it later via email. But we'd really appreciate your feedback. Not audio feedback on the microphone, of course. We've had enough of that today, but we'd really love to hear what you thought of the content and whether or not you think this would be a good venue for covering other topics that would be important to your business and the rest of the business community. So thank you very much to everyone for joining us, and this webinar is officially closed. Everybody have a great day.
Thank you, Kyle.
Thanks, Kyle.